So, Assalamu alaikum everyone. My name is Ahmed Ghazni, and I'll be talking about the challenging total hip arthroplasty in an adult neglected dysplastic hip. And my topic has been supervised by Dr. Parvez Hashmi. So, starting with the history of the patient, she's a 34-year-old teacher and a resident of Quetta. The patient came to us in the clinic with a significant progressive bilateral hip pain. And she mentioned that because the hip pain, she is homebound and unable to walk. The patient mentioned now her mobilization and daily routine activities has been significantly limited because of the pain. And she only mentioned that she can only had limited mobilization because with the help of a walker. And now pain is recalcitrant to analgesics. On examination, she's a young lady with a BMI of 30.2. Her gait was intelligent waddling gait. Her spine examination was normal, and she had some tenderness on both the hip joints. On the detailed examination, her leg length on the right side is 75, on the left is 74. She had about Thomas test and the 15-degree flexion defect on the right and the 20-degree on the left. Hip flexion is about 15 to 80 degrees on the right and about 20 to 90 degrees on the left side. She had adduction contracture on the 5-degree on the left side, and the knee range of motion and distal neurovascular was intact. On calculating the Harris hip score preoperatively, it was 33 on both sides. So this is the pelvis X-ray AP view. We can appreciate and that with the time in the growth, several adaptive changes occurs at both the hip joint. And the acetabulum to form normally and completely, it formed a concentric femoral head to be in the center of the acetabulum to form a true acetabulum. So in this case, we can see a dysplastic, both the acetabular cups and bilaterally completely dislocated femoral head. We can also appreciate there is increased acetabular anteversion, increased obliquity and decreased concavity of the acetabular roof. And on getting the preoperative CT scan of the pelvis, this is the 3D reconstruction images, in which we can appreciate that both the acetabular cups has been completely dysplastic and both the hips have been completely dislocated. So there are multiple changes on the femoral side, which include coxa valga, increased anteversion, the shortening of the neck. And with this, this is not only the bony structural defect. However, the muscles have become shortened because the constant pull, the muscles, contracted muscles, and the moving forwards, there are multiple challenges which a surgeon should be aware of for the total hip arthroplasty in a neglected dysplastic hip. These are, majority of the patients are of the younger age. They have a higher functional demand and they have to mobilize. There is significant deficiency of the acetabular side and there is significant limb-length discrepancy, muscle contractures and aberrant anatomy of the proximal fever. So the patient underwent bilateral total hip arthroplasty on 31st of December 2018, and these are the first postoperative X-rays. So the major concern with the total hip arthroplasty in DDH is the containment or incorporation of both the acetabular cup, which is technically very difficult because of the malformed acetabular cup. So the need for medialization and the proper positioning of the acetabular cup is far the most important thing to be done in these patients. And the postoperative X-rays, we can appreciate that the posterior superior wall was been reformed with the help of a bone graft, and the dual mobility implant was utilized. So these are the lateral views. And the postoperative limb length discrepancy on both the sides, we can appreciate that both the sides are apparently normal. There is about 83.2 distance on the right side and 83.9 on the left side. The acetabular inclination is 53 on the right side and 42.2 on the left side. 1 year follow-up. 1 year follow-up, the patient was walking without support. She has pain-free ambulation. Her Harris hip score was 78.5 at 1 year. So these are the X-rays at 3 years and 6 months follow-up. We can see a well-stabilized implant. Sorry for the bad quality of the X-rays that the patient sent us from outside. At 4-year follow-up, the patient is walking without support. Her gait is normal, and her Harris hip score is improved to 89.5. This is the video which I can of the patient. By looking at the gait, is perfectly fine and normal. She's walking without support and pain-free. The patient mentioned that her life has been completely changed after the surgical procedure. We can also appreciate that she can climb up the stairs and down the stairs without using any support. In this video, we can also see that the patient can actually sit on the floor and can stand up without support. So she had an excellent outcome after total hepatoplasty of both the hip. So talking about the disease burden, in a research done by Professor Masood Umar in our institute, it shows about 1.4% in a general population, and about 68% of osteoarthritis in the hip occurs because of the dysplasia. And about 26% of total hip arthroplasties are performed secondary to osteoarthritis of the hip, secondary to hip dysplasia. These are some more interesting cases. We will go just shortly about a 40-year-old lady from the Gilgit presented with a completely Crow type 4, heart of Achilles type C hip, the left hip, and she had significant difficulty, and these are the postoperative x-rays. The postoperative Harris hip score has been improved from 30.5 to 89.6 at 6-month follow-up, and she did not had any postoperative complications. Another case in which we can appreciate the completely displaced dysplastic hip and dislocated complete hip on the right side. The pre-op Harris hip score of 4053 and the post-operative Harris hip score is improved to 86.6. Talking about some recent literature and our results, comparing it to our results. This is the study done in April 2021, total hip replacement in development dysplasia of the hip by George et al. And published in series. They mentioned that the cyclic loosening was about 15% and sciatic nerve injury was about 5%. And in our study, we compared it that the preoperative score, Harris hip score was about 40.6 and the postoperative Harris hip score improved to 85.5. We had no aseptic loosening in an 8-year follow-up period, and about 2% of patients had a revision and 5% had a protrusion. Thank you so much. Any questions?
If there are any questions, so anybody wants to ask any questions?
So good presentation, Dr. Ghazni. One of the challenges here is to bring the hip center down to the normal center of rotation of the hip joint, which as the grade of dysplasia increases becomes more challenging, and as the age of the patient increases. So did you ever consider femoral shortening here in Crow 4 or even higher cases to bring the hip center down to normal?
Yes, sir. The study that I mentioned, about 20% of the patient with the Crow type 4 had a femoral shortening osteotomy done to bring the normal center of rotation. And in a study done by, which I also quoted in my presentation by Bruce et al. In 2019, it mentions that medialization and complete placement of acetabular cup is the far most important thing in this patient, because placement of the acetabular cup medially and at the normal position lead normal hip center of rotation. With every 1 millimeter lateral displacement increases about 7% load on the hip joint.
Largest series so far, we have almost 57 cases of a DDH. Out of them, there are 13 bilateral adult Crow type 4 dislocation. And out of 13, 7 cases required actually subtrochanteric osteotomy and shortening. And in the last case, you saw that at that time, we did not have any femoral component with a distal locking component, and especially they required a pediatric femoral stem. That's why you need to put a trochanteric plate and at least 2 or 3 screw distally, so to give a better compression at the osteotomy site and the healing. So almost 7 cases in a Crow type 4, they required subtrochanteric osteotomy with a shortening. And the last case, which I did maybe the last month, we have to do almost 2-inch shortening. It was quite difficult. And all of these cases also required a lot of soft tissue releases, and many of them, they do require adductor tenotomy also.
Thank you, sir.
Thank you, Dr. Pervez and Dr. Ahmed. So the next topic in the arthroplasty section is management of periprosthetic fracture. The supervising faculty is Dr. Pervez Hashmi and the presenter is Dr. Umar Rafiq.
Assalamu alaikum. My name is Dr. Sayyid Umar Rafiq, and I'll be presenting a case under the supervision of Dr. Parvez Hashmi. So this is a case of a 70-year-old gentleman, known case of hypertension. He was a resident of Dubai and currently in Pakistan for his vacation time. Was status post bilateral total hip replacement in 2010, which he got done from UK. So he had a history of RTA, which the mechanism was car rollover. This happened in Jamshoro, and he had subsequently complaint of pain in the right thigh and both knee joints. On examination, there was pain in the right hip and pain and swelling of the left knee, and there was a 10 by 4 centimeter wound on the anterior aspect of the right knee, and the distal neurovascular status was intact on both the lower limbs. So the orthopedic injuries that we had to deal with were right hip periprosthetic fracture, and along with a right tibial tuberosity avulsion fracture, and simultaneously there was a left tibial plateau fracture, which was Scharzger type 2. So these are the pre-operative films of the patient, trauma films, and here we can appreciate that the patient has suffered a right periprosthetic fracture, and clearly this is associated with an unstable stem, and the fracture is propagating very distal to the distal tip of the stem. On the lateral view also, we can see that there is a lot of comminution and a vertical split along the proximal femoral shaft. This can be classified according to the Vancouver periprosthetic hip fracture classification as type B3. The other injuries associated were the left tibial plateau fracture of the lateral condyle. Here we can see that there is splaying of the lateral tibial plateau along with depression of the joint line, and a tibial avulsion fracture which was open on the right side. So this procedure was done in a staged manner because the patient was initially not physiologically stable, and initially when the patient was stable enough, we went to the OR and fixed the tibial avulsion fracture with cannulated screws along with washer, and the plate for the tibial plateau along with parosal bone graft for maintaining the joint line. The hip, we had multiple options for the management of the periprosthetic fracture. Here are the post-operative X-rays. We revised the acetabular component with the dual mobility cup, and we used a long stem with distal femoral, distal locking options to get a better stability, rotational stability of the joint. Another plan intraoperatively was to use a long trochanteric plate, but unfortunately the appropriate size was not available. So we used cable wires to stabilize all the bone fragments together. And simultaneously, we also used parosal bone graft to aid in the healing process. These are the lateral views. Here we can see that all the fragments have been adequately aligned, and it seems to be a stable fixation, and the distal locking aids in the stability of the rotational element. So post-operatively, the patient was kept full weight bearing with a knee mobilizer on the right leg and non-weight bearing on the left leg because of the tibial plateau fracture. He flew back to Dubai, and these are the post-operative video ambulation status of the patient. Here we can clearly see that he is walking full weight bearing on the right leg. So recently, Dr. Parvez also went to Dubai to check up on the patient, and he is mashallah doing well and ambulating, as you can see in the video, and there are no current complaints as so far. So thank you.
The forum is open for questions.
Can we go back to the post-op axis, please? Just the hip ones.
Yes, sir. Wait a second.
Nicely done, first of all, I must say. So would you have any consideration about the number of circulage wires you would put across these fragments? Or what would you be thinking in regard of non-union? Because you'll be clearing the blood supply of those fragments by tightening those circulage wires. So how would you prevent that?
So the circulage wires were important because the fracture was severely comminuted. And another thing that we did not appreciate in the preoperative X-rays, that the femoral stem was cemented, which was not so much evident on the preoperative X-rays, but intraoperatively found out to be a cemented stem. So we had to carefully take out all the cement from the medullary canal before placement of this. So
You see, most of the time actually I opt an extra periosteal approach. I try to keep all the soft tissue intact. Although with those C bar you see, you can actually negotiate in between the soft tissue, but do not remove any soft tissue. That's actually my philosophy. So all the soft tissue, they were actually kept intact with that. But the greater trochanter component, it was almost extending as sort of a extended trochanteric osteotomy, you see, that sort of a thing. So I had to put a sort of a tension band wiring. One is actually, you see, there are two K wires also going around the greater trochanter with actually, this is a cable. These are actually not actually circulage wires, only there's only one circulage wire is there. Rest of them, they are actually cable. So initially we thought that we actually assemble all these segments and then try to negotiate, but that was not possible. So we first actually put the femoral component inside and just keeping its antiversion in its place. And then later on, we actually assembled all those bony fragments, held them in its place and fixed them with these. Actually, there are three cables. If you see, two they are around the greater trochanter and one is around the shaft component. And one was the actually screw. So there are three distal screw, and I thought that for greater trochanter, we should have enough support if you have to start an early weight bearing.
The reason I'm pointing this out is that because you have a distal locking screws which is nicely stabilizing your implant. So consider if you have a proximal comminuted femur fracture and you're planning to do an IM nail, so and it's a closed IM nailing. So you don't really put those, comminuted fragments together. You just put a nail in, and you pray that it's just going to heal. So putting all those circulage wires around or the cable wires, you might running in danger of non-union, which is very famous in that particular area as well. So considering all those factors, and I know Dr. Parvez did it, so the question was from you, because he put some bone graft and everything there as well, considering all those factors. So yeah, nicely done. Thank you.
yeah, thank you, sir.
Thank you,
Yes,
everyone.
I think it's a very good point. So we will, I mean, with this kind of open surgery, these external soft tissues are already compromised. So you want to achieve maximal stable fixation. I mean, I'm also looking into that way. Sometimes when you do open nailing, you still take cell fragments with the cerclage. That's why the AO teaching is as well. So probably the new system which we saw in the city recently, with instead of plates, they are using rods with variable angles, screws. So that may remove this need of so many cerclages in these kind of fractures. So maybe you people may have seen those systems as well.
Yeah, you have those plates available with variable angles for the screws that can avoid the implant stem and just catches the fragment, and which is very stable as well. And sometimes you can get, just because of that problem with the soft tissue and blood supply, you have cable plates as well. So you can put the plate with the cables, and that really take the pressure, and that's again a very good implant to use in such scenarios.
Thank you, everyone. So we would conclude the arthroplasty section and start with the hand and wrist plus microsurgery. So the first presentation is on the topic free vascularized fibular graft for large bone defect. The supervisor is Dr. Parvez Hashmi and presenter is Dr. Omar Rafiq.
Bismillahirrahmanirrahim. So, moving on with the next presentation. So, this is a case of a 12-year-old boy known on comorbids. He had a history of RTA, which while the mechanism was that he fell from a bike. He had open distal tibia and fibula fracture, which was Gustello-Anderson type 3B. He was initially managed in Larkana with X-fix and daily dressings, but on presentation he had a wound of about 25 by 15 centimeter on the anterior aspect of the lower leg with exposed bone, which seemed to be non-viable, and the wound was also infected at the time of presentation. So initially, this was the X-rays that the patient has sent me. And this was the management done in Larkana, and this was the condition of the wound. Here we can clearly see that there's a large defect about 15 to 20 centimeters, and the tibia is exposed, as well as the uh, fibula. So initially, we went in for wound debridement, and we excised all the dead bone, which resulted in a defect of about 10 centimeters, as it is evident in this radiograph. And the X-fix was adjusted at that time. Another wound debridement was done, and the patient was planned for coverage of the defect along with the dealing of the bone loss. So, how to deal with the bone loss? Shortly summarizing this, if there is acute shortening, then if there is a small bone defect, then acute shortening can be done. The other option can be to fix the fracture and apply to cover the wound with a soft tissue coverage, which can be done in internal fixation when feasible, and soft tissue coverage plus bone grafting. And the other option is a free vascularized bone graft. The third option would be a bone transport. So we opted for the free vascularized fibular graft from the contralateral leg, and these are the immediate post-operative X-rays. And this is an intraoperative picture of the coverage of the defect. Here we can see that the on osteocutaneous flap was raised from the contralateral leg along with the vascularized fibula and was placed to cover the defect and uh, to align the bone. And this was the donor site which was planned. And these are the post-operative images of the wound about 2.5 months later. So sequential X-rays were done to see how the free vascularized fibula was hypertrophying. So these are the X-rays at 2 months, and in the X-rays of 4 months, we can see that the bone has integrated both proximally and distally. And at 6 months, we can see that the bone has started to hypertrophy, and at 15 months, we can clearly see that the fibula has almost gained the circumference of the tibia, and with well with broad cortices and seems to be a stable fix. Here is a comparison of the immediate post-operative X-rays with the X-rays at 15 months. The varus at the ankle was also corrected by weight bearing. And here is the lateral X-ray for comparison. Here is the wound, the recent picture which was taken last week. The donor side is also healed with no donor side complications. And here is a short video of the gait of the patient. He is much full weight bearing without any support, and he is going on in life without any complications. So a little about the vascularized bone grafts. So vascularized bone grafts are indicated when bone transport is not feasible, and if the bone defect is more than 6 centimeters, and also when soft tissue coverage is not available. So the pros of the vascularized fibula are it fills the gap with the osteocutaneous or osteocutaneous along with the skin flap, and there is early union. There are no issues of patient compliance with compression and extraction, and the bone hypertrophies with time. The cons can be that initially there is protected weight bearing for a few months, and there is a chance of stress fractures, and it is a prolonged surgery. And also it requires a technically demanding surgery it is. So here's an recent article from 2020 in which the treatment options for infected bone defects in the lower extremities, free vascularized graft versus elixir of bone transport was discussed. And they concluded that both free vascularized fibular grafts and elixir of bone transport are effective methods for repairing and reconstructing infected bones and infected bone defects of the lower extremities with unique advantages and limitations. Generally, the free vascularized fibular graft is recommended for patients with soft tissue defects and bone defects adjacent to joints and large bony defects, which was exactly our patient. So thank you, and any questions?
Yeah, nice, again, very nice case. But I did thought that there is some degenerative changes in the ankle joint. Was there or something? Maybe just the image looks like that.
He had lots of actually along with their sensor and cranial compartment. This ankle joint is okay, there is some intimate ankle joint. But my plan was once a bone becomes hypertrophic. So you see, he had a loss of interior as well as the peroneal compartment. There's a loss of anterior tibial nerve, anterior tibial vessels, and a big soft tissue defect, which we have reconstructed, bony as well as a soft tissue defect. Now the next stage is to reconstruct, give him a motor transfer. Like tibialis interior, it has to be reconstituted, but we do not have any local transfer available. So he has some muscle mass in the upper two-thirds of leg, and maybe with some tendon graft, we can still actually do, because there is no supple soft tissue on the interior compartment, we can do actually tendon transfer just like we do peroneus longus to the midfoot for the foot drop. And similarly, my plan is I will do that. But now let the fibula become hypertrophic. It usually takes 2 to 3 years, because in my experience, I had replaced almost a whole humerus with fibula and half of tibia with the fibula in the past also, with this microvascular technique, and that gives an excellent result. So with the weight bearing, it becomes almost a tibia. And over the 2-3 years, you will see that nobody would be able to recognize it, either it's fibula was transferred there or not.
Very nice, very nice.
So the spin is actually, if you see, the spin is in the talus, not actually in the we tried to save his growth plate. And we have to follow it, how the growth plate behaves over the period of next few years. It looks like that so far, There is no shortening, but we have to see over the period of next few years.
Thank you.
Thank you, everyone. So the next topic is revascularization in Kienbock's disease. The supervisor is Dr. Harun Rashid, and the presenting resident is Dr. Ziad Ali.
Assalamu alaikum. My name is Dr. Ziad and I'm finally a resident in orthopedics. So I will be presenting case of revascularization in Kienbock disease. And this patient was 18-year-old girl with right hand dominant. She presented to us in February 2020 with history of left wrist pain and swelling in the dorsum of the wrist from 10 months. On examination, she had swelling and tenderness on the dorsum of the wrist with with significant restricted range of motion. So on initial visit, we performed X-rays in December 2019, and these were the initial radiograph. You can see there is a negative ulnar variance and associated sclerosis of the scaphoid in the PA view. And in the lateral radiograph, you can see that the ulnar lip of the scaphoid is fractured, and there is fragmentation with sclerosis. So she was given option of surgery, and she opted for second opinion, and she then lost to follow up, and then she again presented on 19th August 2020 with aggravation of the symptoms. She had significant wrist pain, and then these were the X-ray radiograph that were done again on 19th August 2020. In the PA view, you can see there is significant collapse of the lunate bone with the negative ulnar variance, and similarly you can see in the lateral radiograph, you can see there is significant fragmentation and collapse of the lunate bone. So according to Leishman classification, it is classified as stage 2B, 3B, and according to the Bain and Beck classification, it is classified as type 1. So there are multiple treatment options in this with joint leveling procedure in the form of radial shortening and ulnar shortening and vascularized pedicle grafting, core decompression, and prosthetic lunate replacement. So all these procedures are demanding in the form of vascularized pedicle grafts, different pedicle grafts we can take, but these require expertise, and similarly lunate replacement with the prosthetic replacement has their own pros and cons. So we opted for a simple procedure on 20th August 2020 in the form of radial shortening, and in which we proceeded with the 3 centimeter proximal to the radiocarpal joint. We did transverse osteotomy, and that was 53.5 mm LCP, and the joint line was maintained. So these are the immediate post-op radiographs, and these are the 1 month down the line of the index procedure. This is the 2 months post-op radiographs. You can see there is callus formation at the osteotomy site, and these are the 2-year post-op radiographs that was done last week, and you can see there is complete healing at the you can see there is reestablishment of the lunate as well as there is complete healing at the osteotomy site. And these are the lateral radiographs. You can see the lineate is re-established. So these are the clinical visit video in which you can see she can do full range of motion at the wrist, radial and ulnar movements as well as so she is doing all these movements without any pain, and our wrist grip is improved. So this is a study regarding the joint leveling for advanced Kienbock disease, and in this study they have seen that in stage 3B wrist that there is static carpal mal alignment does not preclude the radial shortening osteotomy, and that it is an effective procedure and a simple procedure. It can be done by any orthopedic surgeon without need of any expertise required for the microsurgeries or any other sophisticated procedure. So this was all about this. Thank you.
Any questions?
That has just shown the plus side of this case. The downside was I think too much of surgery, too much of fixation, and now the osteotomy and fixation has been modified. So you go more proximally, like you start your osteotomy on the lateral side and end up in an oblique osteotomy, end up on the just inferior border of the radioulnar joint, and just fix it with one screw. Headless screws, very good implant. So one screw is good enough. So that was the downside of this case. And you could see I was about to counsel them for bone grafting. If you see the early post-operative, there is a characteristic, all characteristic feature of heading toward non-union. And I was about to counsel them for bone grafting कि ये तो heal ही नहीं होगी, अब इसको कुछ करना पड़ेगा, and she disappeared. And then she appeared later on, and she came for just to say thank you. I got rid of pain and my emotions are good. I am back to work. So sometime you do have such type of blessing. I think this is, to me, the only downside is this is too much of fixation. And for resident, my question is, what will you do if you don't have minus ulna? Capitate, very good. So capitate shortening or dusre should have given some outline about the biomechanics of the wrist, by which are related to the length of radius and leveling, as well as the ulnar inclination. So you do radial shortening and change the ulnar inclination. So an oblique osteotomy, which is like a closing wedge osteotomy, wedge is located on the lateral side. So you just change it about 5 degree, and that changes a lot in biomechanics from leonate fossa has 48% and 52 relationship. So this is almost a significant change with only 5 degree of angle. So that is the biomechanics involved in this case. So maybe Professor can comment on it because he has more experience than me about leveling procedure compared to the revascularization. So I have never done revascularization.
Harun, thank you very much for showing this excellent case. You see, the nature has helped. Many times we have a doubt in mind that even if you do laterally based closing wedge osteotomy, which actually serves the two purposes. One is it's a leveling procedure. With the shortening, you bring the relationship of radioulnar joint, and take off the pressure over the lunate along the axis of wrist. And the second is when you improve its inclination, especially ulnar inclination, lot of load actually goes away from it. And now you see the nature has shown simple closing wedge osteotomy has solved the procedure. And still I will say it's not actually a big procedure. You see, nowadays people they recommend that the osteotomy has to be done at least 3 to 5 centimeter proximal to the wrist joint. Now has become standard. Previously, I used to do osteotomy much more proximally, where I was doing actually intercompartmental bone grafting based on the third pedicle. I usually do both procedures simultaneously. I do a shortening if it is a minus ulna, but at the same time, my main procedure is on the third from the distal radius. I take a bone graft of almost a 12 millimeter width and almost 8 to 9 millimeter. You see a long bone graft based on the third intercompartmental artery and put it inside. And even in the last week, we did one case and I showed them that how to do it. We have a lot of pictures, and maybe in our Arthocon, I'm going to show my series also, because I will talk about all those supraretinacular and intercompartmental small vascularized bone graft based from the distal radius, from the metacarpals, to vascularize either scaphoid or the lunate. These are the two most important bones which have a high incidence of a avascular necrosis, and to prevent that, those vascular bone grafting. But having said that, you see, even vascularized bone graft, many times they do not give a 100% result. You see, many times symptoms they do improve, but the revascularization sometimes doesn't occur. And revascularization is 80 plus in the different series. So, but this is an excellent example to show to resident and to the rest of our orthopedic community that simple leveling procedure, as well as to improve ulnar inclination, it takes a lot of load over the lunate, and nature helps.
Thank you, Dr. Parvez.
Another comment is about classification. So I'm sure it is sooner or later will apply to the head of the femur, MRI based classifications. So which can explains that if the cartilage is gone, whatever you do, you are not going to, revascularization is not going to help. If cartilage is good, then all salvage procedure, whatever the situation inside the bone is. So that may apply to the salvage of the avascular necrosis of the femoral head in case of non-union. So MRI may be helpful in deciding that either to salvage or not to salvage the joint. Thank you.
Thank you, Dr. Haroon. So we will now proceed. So the next topic is brachial plexus injury, all 5 root avulsion. Supervising faculty is Dr. Parvez Hashmi, and the presenting resident is Dr. Marid Zahid.
Assalamu alaikum, everyone. I'm Dr. Marej, and I will be presenting a case of all root avulsion in brachial plexopathy, and my work will be supervised by Dr. Parvez Hashmi. So I'll present a case of a 20-year-old girl who had no prior comorbids, who had a history of road traffic accident, pedestrian versus car in November 2020. She suffered a fall and impact on the right shoulder, right side of the shoulder and the neck. And initially, she was managed at trauma center, and she also had an associated right tibia fracture for which the RF was done in just the same month. So she presented to us with in the clinic with the complaint of inability to move her right arm since the RTA, and there was no recovery. So in examination, there were all the motor units were 0 by 5. On investigations, the MRI cervical spine was showed empty roots, and EMG NCV was done, which showed a right supraclavicular brachial plan plexopathy. So we planned for a triple nerve transfer here, now this time it was different. Initially, when it was the suprascapular nerve was probed with a nerve stimulator, the nerve stimulated. So there was a change in the plans with a conventional triple nerve transfer, where you do a spinal axis transfer to suprascapular nerve, and then phrenic nerve to musculocutaneous nerve, and then the opposite C7. So this was different this time. So Dr. Hashmi did a spinal accessory to musculocutaneous nerve, and that C7 was transferred to the median and the posterior cord using a vascularized ulnar nerve graft. So the median is vascularized with the with the vascularized ulnar graft, and the posterior cord was brought with the help of a humeral shortening, which gave of 5 centimeter length, and the posterior cord was also moved to the posterior division of opposite C7, and then biceps was routed and around the clavicle and plicated back. So this was a 1 year follow-up. Was the right shoulder abduction was 10 degrees, right elbow extension was 40 degrees, right elbow flexion was 60 degrees, wrist extension was also there, and thenar muscle wasting was again there was present, and hypothenar as well. So tinal signs started to appear, and no sensation on the wrist or hand were there. So this is a 1.5-year follow-up, where you can this is a surgical scar all the way through the neck until the mid arm, and then all the way from the hand, harvesting the ulnar nerve along with this vascular supply. So this is her short. I made a short videos of her doing elbow flexion and extension against the gravity. So bit of 40 degrees around range of motion at the shoulder, forward flexion. Deltoids were, good deltoid bulk is present currently. There is a wrist extension against the gravity. And it's the sensations are intact, except that the ulnar nerve distribution of the little finger, and tinals is positive. So we are hoping for a recovery in the median and median nerve distribution, and then the extension of the fingers. Rest is so it's a 15 months follow-up right now.
Yeah, you see, when all 5 roots they are avulsed, you do not have any motion and sensation in the whole upper limb. Your shoulder is paralyzed, except the trapezius is intact and the rhomboids they may be intact, depending upon if the injury is supraganglionic or infraganglionic. And you do not have any motion at the shoulder, elbow, and in the hand. So objective here are to stabilize the shoulder, and second, to provide some flexion at the elbow joint and some motion at the wrist. So these are the 3 major objective in all 5 root avulsion. And for the shoulder, now it's almost uniform that you have to do a transfer of a spinal accessory to the spinatus muscle, and especially that would be the suprascapular nerve, because with the suprascapular nerve innervation, you will have a supraspinatus and infraspinatus, which will stabilize the shoulder and will give some abduction up to 40 to 80 or 70 degree. The second is you transfer musculocutaneous nerve to the phrenic nerve. Transfer of musculocutaneous nerve with the phrenic nerve, people they start in elbow flexion. And then for median and ulnar nerve, you do opposite C7 transfer. You see, you dissect the opposite C7 transfer. Once it divides into its 2 branches, one an anterior devian, another is the posterior devian. Just distal to the devian, up to 1 centimeter, if you resect it, and the opposite limb, you will not have any sensory or motor deficit, except a temporarily hypoesthesia in the thumb and index finger, which improves over the period of next 3 to 6 months. That's the only deficit people they have. So there are 3 different categories of opposite C7 transfer. One which was described by the Gu from China, in 1988. I think he should have been awarded any uh, prize for his actually innovation. But you see, the European and the American, they have not given him any award. He actually did his experiments in the rats and the pigs and then the dogs, where he did a opposite 7 transfer without any functional deficit. So he took actually ulnar nerve based on a vascular pedicle. He dissected the ulnar nerve from the axilla up to the wrist joint. In the distal 1/3 of a arm, ulnar nerve actually gets a vascular pedicle from the brachial artery, and it is called medial collateral artery, just like a profunda brachii artery. Based on that pedicle, ulnar nerve distal end, which was dissected from the wrist, it went with a subcutaneous tunnel up to the opposite neck, where he anastomosed with the opposite C7. Proximal end of ulnar nerve, it was anastomosed with the severed end of median nerve in the axilla. So it gave actually a good recovery over a period of next 2.5 to 3 years. And people, they started to have a motion. They had a sensation in the index, middle and thumb, which is called the eye of hand, and some flexion at the wrist joint. And later on, they actually orthodized the wrist. Later on, his students, when in 2008 and 9, actually I visited him over a period of few weeks. China, he is not able to actually speak English, but his students, they were actually very well versed in the English language. So they actually started to do a shortening of humerus. With the shortening of humerus, they dissected the whole brachial plexus in the neck, and then they opted a retropharyngeal route. Behind the esophagus, they anastomosed median and ulnar nerve to the anterior and posterior division of a opposite C7. So, and with my visiting fellowship in Thailand with Professor Punopan, he had a biggest series all over the world. He had almost 3,000 cases of opposite C7 transfer. Now, what they observed in the clinic, when people, they were actually swallowing, during deglutition, they felt pain going all the way into the opposite hand. So then they actually stopped doing that. Then they opted a route in front of a trachea. So they brought actually opposite C7 in front of a trachea and started to do anastomosis. So in this case, what I did actually, vascularized ulnar nerve, it was transferred, and similarly, and it was anastomosed to the interior trunk of C7, while the posterior end was anastomosed to the posterior cord. Now with that anastomosis, direct anastomosis with the posterior cord, you see this girl had actually power in the axillary nerve, innervated muscle, which is a deltoid. And you can see there is a good power in the triceps, in the wrist extension, and the finger extension also. So with the direct anastomosis, you have a better outcome. Still, she is improving. She will have some function in the hand also with the fist making. So that was actually my comment.
And one more thing, that she had, the one not surprisingly for Dr. Hashmi, but yes, when he examined her, so the tunnels kind kar rahe the, so she also had the sensations over her left hand. So opposite, due to the opposite C7.
So in terms
Using
of
for the
day-to-day
residents, yeah.
activity, when would you expect to have some sort of normality for functions, or how long does it normally take?
Usually it takes almost more than 3 years before they have some good function. And many times these people, they require a secondary procedure also. And secondary procedure is stabilization of wrist in form of wrist orthodesis and some tendon transfers, so that they can actually make a fist. They can hold a major object. Now here objective and the gain would be, there is something better than nothing. So that's the game. But if you ask these people that what is the most important function with which you are happy, and they say it's an elbow flexion. And elbow flexion always comes in these patients, and shoulder stabilization. Now we don't do actually shoulder orthodesis nowadays. It is now almost a past. With a transfer of a spinal accessory to the suprascapular nerve, they have some abduction at the shoulder. And with the phrenic nerve to the musculocutaneous nerve, they have a good function in the elbow flexion, because if you anastomose with the musculocutaneous nerve, there is some reinnervation of a lateral pectoral nerve also. So they do have some pec major also.
Thank you, nicely done. Well done.
Thank you, Dr. Parvez and Dr. Marij. So we'll now be proceeding to the section of deformity correction. The topic for today's presentation is knee genu welcome with patella dislocation. The supervising faculty is Dr. Masood Umar, and the presenting resident is Dr. Rufina Ali.
Assalamu alaikum everyone. I'm Dr. Rufina Ali, resident orthopedics, and I'm presenting my case of left knee genovalgum plus recurrent patellar dislocation. My work is supervised by Professor Dr. Masood Umar. So coming towards my case, she is a 23 years old girl with no known comorbids, and she was presented to us with a progressive valgus deformity of left knee since 8 years, and complaining of left knee pain since 2 years, and then the more concerning about the left patella instability since 3 months. On examination, she had antalgic and valgus thrust gait, a wall marked valgus deformity. Her J sign was positive, and there's a tenderness at epiphyseal site of insertion. And she had fixed patellar dislocation. Distal neurovascular was informed, intact. On the mechanical alignment, her Q angle is 40 degree. Tibiofemoral angle is 38 degree. Intermalleolar distance is 19 centimeter, and her beaten score is 5/9. This is her pre-operative gait video. You can appreciate there is a valgus thrust gait. This is her knee examination. You can appreciate dislocated patella. However, there is some degree motion in patella. However, this is the fixed patellar dislocation. We did X-rays, left knee standing AP and lateral view, in which you can appreciate the left knee valgus deformity. We did scanogram to rule out the deformity, whether it's femur and tibia. So this is the AP standing lower limb scanogram. We can shows the deviation of marked deviation of mechanical axis on valgus side. The mean axis deviation towards the valgus side on the left side is 64.8 mm. So coming towards the angle, her lateral distal femoral angle is 70.5, which is marked unstable, and her medial patellar tibial angle is 95.4. So we calculate the cora of the distal femur, and which is about the 68.8 mm, which is about 7 centimeter from the joint line of the distal femur. And we calculate the cora of the tibia, which is also at the proximal tibial side, 2 centimeter below the joint line. So in this case, the problem is deformity mainly in femur and also in a tibia. And there is a marked patellar dislocation and also the epiphyseal ligament protrusion. So our plan was correction of femur, correction of tibial deformity, improve patellar mal tracking, medialization of tibial tubercle, lateral release, and epiphyseal reconstruction with gracilis tendon. This was our plan. In this plan, first we did osteotomy and the distal femur corrective osteotomy 8 centimeter from the joint line, and which is fixed with the retrograde nail. And to fix more stabilization, we put 2 polar screws, two on the medial side of the proximal segment, and one is the distal side. And then we did the supratubercle osteotomy, and we did distalization and medialization of the tibial tubercle as well. After that, we checked the patellar tracking. Patella is still unstable, so we have to go for the lateral release, and then lateral release and epiphyseal reconstruction with the help of the gracilis graft and suture anchor. These are post-operative images. We can appreciate there is alignment is well corrected, and this is a retrograde nail with the proximal polar screws, and also the tibial tubercle osteotomy fixed with screws and plates, and these are the anchor sutures for the epiphyseal reconstruction. These are the intraoperative picture which can shows the patella is stable in the range of motion. So these are the post-operative scanogram, which you can appreciate the alignment is correctable. Mean axis deviation is decreased up to 12.5 mm, and the angles are much more corrected, which is lateral distal femoral angle is 81 and medial proximal tibial angle is 84.6. These are our 5th-month post-operative video, post-op X-rays, which shows the osteotomy is healed and alignment is well corrected. These are femur X-rays, and these are the 5th-month follow-up video. Patient is now walking. We hold the support, remove the support, and walking with support. His alignment is corrected as you show in the video. Knee range of motion, knee is still now stiff. We advise physiotherapy, and we are working on his knee range of motion as well. So there's an article which closing wedge distal femoral osteotomy combined with the medial patellofemoral ligament reconstruction for recurrent patellar dislocation with genovalgum. They used 25 patients with average 19.8, and they shows the combined closing wedge osteotomy and reconstruction is a suitable treatment for this type of genovalgum and recurrent patellar dislocation, which leads to the significant improvement in clinical and imaging finding of the knee in the short term. So in the last, the aim of our surgery is the correction of alignment and the patellar stability. However, there is a very short post-op follow-up period, but still the alignment is correctable and patella is stabilized. Thank you. Hmm. Thank you, sir. Hmm. Debuilder. Mhm. Mm. Thank you, sir. So actually, we did supratubercle osteotomy, and we did tibial tubercle distalization and medialization. Closing.
Tibia, no wedge was removed. It was just compression of the cancellous bone.
Mhm.
And some PowerPoint help will help you in explaining osteotomy. So I think by opening wedge, he means that not wedge removal, but just the mechanism of correction.
Yes, sir.
So वो paper पे अगर आप लोग draw कर लेना, that certainly help to explain.
Mm.
If you go back to the previous slide,
Yes,
yeah,
sir.
here. So the osteotomy cut was made, limited exposure, and then the cancellous bone was just compressed into each other, bringing the distal tibia into varus, and then fixed with a plate. वो scanogram है ना, post-op. See? We overcorrected deliberately, so we are into varus within range, less than 15 mm of varus, 12 mm. So that's why we did not require a big wedge removal, which is your question. Most of the correction was already achieved at femur. We had some residual valgus which we corrected at the tibia.
maybe this pre-op and post-op in one slide. Probably that would have been the mental representation that how much reduction has been done.
Sir,
Sir,
I have two, three queries for that. One, what was the disease or reason that patient was having this valgus? I think so. He started around 16 years of age till 24, and it was a unilateral. One thing for I want to know about why you prefer this retrograde femur nailing over medial close wedge osteotomy of the femur. In this case, you might be able to at the same time go for the MPFL reconstruction also. So what was your thought you preferred nail about it in the distal femur correction?
Wo Kazim, I think it is probably not metabolic disease since it's unilateral.
Okay.
Probably some trauma which he doesn't recall to the probably the lateral femoral growth plate. I think way back in her childhood, which went unnoticed. So that probably led to overgrowth of the medial femoral condyle and progressive valgus, and then subsequent dislocation of the patella. And now the reason, as is customary in our circumstances, was her marriage, and so that's why parents brought her over for treatment. So now the next question: femur nail is a closed procedure, right? So it was a small single incision. If you can show the incisions. One thing Dr. Rufina forgot to mention: before I did anything, I released the peroneal nerve, which you see the big lateral incision. That's the only bigger incision. Peroneal nerve was released from the top to the bottom. As explained by Paley in his book, it has 3 points of fixation. All 3 were released. And so acute correction of valgus is always associated, must always be pre-associated with a peroneal nerve release, which was done here. And these lateral scars are for the locking screw, and osteotomy was also done through that, through small locking screw incision and osteotomy scars are combined. So this was a closed procedure for femur, and that's why I preferred not to remove a wedge from the femur, and just translation of the distal femur. If you plan it accurately and plan your polar screws accurately, it should suffice. And this is technique I have learned from my friend Dr. Harun. He is the master champion of this. And we also applied Dr. Fina fixator. The fixator was applied, as you see in the pre-op planning, if you show. No, either. So fixator was applied here to correct and hold the correction, and then we pass the nail, right? So that point has uski koi picture nahi hai, lekin that was done as a separate procedure, and then the fixator is removed once you pass the nail and lock the nail. Yes, I was expecting that question from you. I know you would have done a tibial nail. I was actually, एक तो correction इतनी ज़्यादा ज़रूरत नहीं थी, और फिर मैंने उधर काम भी करना था, tuberosity को भी करना था, खोलना तो था ही. That's why I erred for a plate fixation for tibia rather than a nail. But this was just subjective. I think no science behind it.
He's a big steward. Now 5 months has passed now.
वो सिर्फ सिटी मीटिंग की कंपल्शन थी, इसलिए हम ले आए. नेक्स्ट ईयर आपको फॉलो अप दिखा देंगे. 3 months मैंने इसको इमोबिलाइज रखा है, और बहुत आहिस्ता इसकी मैं डिलिबरेटली बहुत स्लो रेंज ऑफ मोशन शुरू कराई है. वो एक्टिव मोशन तकरीबन 60-70 इस पे नज़र आ रही है, लेकिन पैसिव अबाउट 90 तक है इसकी विद ग्रेविटी असिस्टेड. जब ये इस पे एज ऑफ द टेबल पे बैठती है तो ऑलमोस्ट 90, लेकिन वो बढ़ जाएगी क्योंकि मैंने इसको बहुत स्लो रखा है. आई वाज काइंड ऑफ wanting to heal, wanting all osteotomies to heal first and then focus on range of motion program. That's why. शादी मैंने 1 साल डिले करवाई, तो वो इंशाल्लाह हो जाएगी. Yes, that was one indication.
Thank you, Dr. Masood and everyone. So now we'll be proceeding to the sports section. Our topic is PCL avulsion. Supervising faculty is Dr. Naveed Juman and the presenting resident is Dr. Vajahat.
So coming back, Kazim, would you prefer a medial closing wedge for this case? Just your
So
opinion.
honestly, it's what I do in my hand. So yes, I will rather, if I'm going to learn about this technique, of course, after that I might plan for retrograde. But what I know and how I do is basically medial close wedge osteotomy in this field. You first need to be learn about it, have an experience to execute to have the same outcome. That what is in your hand.
If the contact becomes less than 50%, so you do have delayed healing, but I know we are okay with this without removing any wedge. All close osteotomy.
So I think so. The biology is very much preserved. It is a minimally invasive. So of course the healing it's always potentiate, and that's at the metaphysio diphysial junction. That's another part that will going to help to have a better callus formation.
Apologies for a minor delay. Okay, so now we'll first be presenting the trauma section. The topic is complex acetabulum fracture. The supervising faculty is Dr. Naveed Juman and the presenting resident is Dr. Marich.
Assalamu alaikum. So a little disclaimer that the complex acetabulum fracture might not be that complex for many of you. So, so let's start with the case. She's a 68-year-old lady who is hypertensive and she was function class 1, presented with history of road traffic accident, which is a high velocity car versus car head-on-head collision. She presented to us in ER with complaint of pain in the right hip and unable to bear weight on the right leg. So on examination, she was an elderly lady, morbidly obese that time, and she had the vitals and subvitals were normal. There was a bruising over the right lumbar region and the trochanteric region, the right hip. There was painful motion at the hip, and there was a leg length discrepancy at the of 3 centimeters. On the right side, there was a shortening, and the sciatic nerve and the distal pulses were intact. So these are the X-rays pelvis AP on the presentation, which shows there is a subluxation of the right hip. There is a gull sign over here, and there's the operator oblique views and the iliac oblique views. You can appreciate there is a significant subluxation near close to dislocation. So these are the CT scan. So she had no other associated injuries other than this. These scans shows the axial view, and I can start playing the coronal views as well. You can appreciate the CT. On the coronal views, there is significant. Let's play it again. So there was an isolated posterior wall fracture. And you can appreciate the 3D reconstruction of it. So this was a large fragment here of the posterior wall, and there was a significant impaction at the acetabular site. So we were just there for discussing that either should go for straight away fixation or this fixation with total hip. So the options were given to the family. The family denied for a total hip at the time. So so these are the intraoperatives. We did made a Cocker-Langenbach approach. So there, next. So there is the view. So this was the acetabulum. This was the articular surface, and this was the head of the femur. So this was amount of the impaction that was caused by the fracture, and we had to lift off and filled it with with some cortical graft. It was taken from the posterior iliac crest. So these were the cortical chips, or we can say bars, which we placed here for a structural support. Then we placed a morcellized cancellous graft in between the fragments. So, and here was a posterior wall fragment, and we can appreciate it here. And so we covered it up later in that. So this was a technical challenging. So we placed a spring plate. 2 spring plates were placed after reconstructing it and putting on the wall fragment. And then we placed 2 spring plates, which were regular T plates. And then we also placed a reconstruction plate of 3.5 mm. So, and post-operatively, so there are the C-arm images. We can appreciate that none of the screws is entering the joint. The post-operative course was like she was kept on a skeletal traction for around 3 weeks with intermittent knee range of motion while removing the traction, and she was kept non-weight bearing bed to chair for another 3 weeks, and then it was shifted to partial weight bearing. Was started at 6 weeks, while full weight bearing at 3 months post-operatively. So these are the X-rays, pelvis AP, inlet and obturator, iliac oblique and obturator oblique, pardon. So which shows that the fracture is healing in a while, and where we did not appreciate that sclerosis or the hip joint. These are the 8 weeks post-op X-rays. We can see the reduction of a joint space here. And this was a 15 weeks post-op. You can see that it is reduced and the fracture has healed. And this is a 10 months follow-up, which was recently taken. These images were taken 1 week back. So this is how she walks now, with a stick, and she has bilateral knee osteoarthritis as well. And so after a long waiting, this video was made, unfortunately. So now she's happy with the pain. So currently the range of motion is around 60 degrees of flexion, hip flexion, and abduction is there around 40 degrees, and external rotation is there. However, internal rotation is restricted pretty much. So the question like whether we would do a total hip that time or later, so to bridge the gap between the two procedures. So we had I searched out the articles that while seeing the acute versus delayed total hip arthroplasty. By the way, the patient is well counseled about the post-traumatic arthritis that occurs around in 2/3 of the patients. So especially in the elderly. So there was a quick facts I could obtain for the learning of sub-residents. There's a global burden like 12 to 14% of acetabular fractures occur in patients older than 65 years of age. It might be due to high velocity or lower velocity. The non-operative treatment has been associated with a poor outcome and increased mortality. As we all know about the bedridden patients and elderly. So ORF in the elderly is associated with inferior outcomes as compared to the younger population. And 2/3 of the cases treated with ORF require conversion to total hip arthroplasty within 3 years of time. These were taken from a meta-analysis. There is still a debate over while doing acute total hip with ORF versus delayed. Delayed means of two types of giving a trial of non-operative and then doing a total hip versus ORF and total hip. So in this study they compared the acute ORF with acute total hip and ORF with delayed total hip. So there are certain advantages and disadvantages of both the procedures. So the advantages of doing in the same setting is no secondary procedure, immediate full weight bearing, and the disadvantages were involves the complex arthroplasty and expertise, use of acetabular cages or wedges for cavitative defect, while in the delaying it and then doing it, so requires a second surgery procedure. Obviously a total hip arthroplasty, it is simpler than the acute total hip arthroplasty most often, and then there are less complex implants are required. The disadvantage again is a prolonged immobilization. As you fix it, but you cannot immediately start weight bearing, you wait for 6 weeks in our case as well. So the total of 26 patients were there, and they saw all of these variables. There no statistically difference in terms of acetabular inclination, anteversion, heterotropic ossification, complication rates like periprosthetic joint infection, dislocation, and blood loss. However, there was a statistically difference in terms of Oxford hip score, which was better in doing it acutely. So another study which found that the risk factors for conversion to total hip arthroplasty after acetabular fractures involving specifically for the posterior wall. So they included 5 variables of the radiographic features were there: presence of dislocation, combination of posterior wall, femoral head impaction, acetabular impaction, and intra-articular loose bodies. So they concluded that the presence of all 5 radiological features, if they are completely associated with 50% rate of conversion to total hip arthroplasty, in contrast to 11% if 4 or less are there. So this was for the prognostic implication and what you need to counsel the patient. So in terms of fracture reduction, so this is a Kaplan-Meier survival curve based on the reduction quality. So they also isolated that if the reduction quality is very good, as in less than 1 millimeter of step off as done on the post-op CT scan. So there is a 0% total hip arthroplasty rate. So when there is 1:4 millimeter step off, then the 9.1%. And if there are more than 4 millimeters gaps, then it ranges to 53% of them. So that's all from my side. Thank you.
Can you show a few of X-rays and just tell why this double head shadow is being done? These are 2 linear shape shadows. That shows actually really infection. One has to anticipate looking at that it is suppressed. And once you will actually try to reduce it, pull it down, there would be a gap inside. So you have to put an extra gap like that.
Yes. I hope the residents got what Dr. Hashmi is trying to say. Any further comments on the fixation? Okay, thanks.
Okay, thank you, Dr. Parvez and Dr. Marich. So now we will be proceeding to the next topic, that is fracture elbow dislocation. Supervising faculty is Dr. Harun Rashid and presenting resident is Dr. Hamar.
Assalamu alaikum everyone. My name is Amar and I'll be presenting a case of complex elbow dislocation. My work has been supervised by Dr. Harun Rashid. So he was a 52-year-old male with no known comorbs. He was a 52-year-old male with no known comorbs. He was a commercial pilot in PIA and right-hand dominant. He presented to us with history of ground level fall about an hour back, and he had impact on his right elbow. At presentation, his complaints were pain in his right elbow and inability to move his elbow since the fall. On examination, he was a middle-aged male, alert, oriented, and vitally stable. Right elbow was swollen and it had gross deformity. It was tender. The DRUJ was stable though. It was extremely painful on passive movements, hence range of motion was not tested completely. The median nerve, on examination of the median nerve, opposition was intact and sensations were intact as well. And on examination of ulnar nerve, his SU was had a power of 1/5. Palmar and dorsal interossei had powers of 1/5, and sensations were altered. And on examination of his radial nerve, EPL had power of 1/5, and ECRL, ECRB also had powers of 1/5. The sensations was also altered. So X-rays were advised, and these are X-rays, AP, and somewhat lateral view of his right elbow, showing a posterior lateral fracture dislocation of his right elbow. So the dislocation was reduced in year, and these are post reduction X-rays. These were done using a portable X-ray machine. And based on the complexity of the fracture and the injury, CT scan was advised. So these are once the CT scan was done, it was found that his elbow had again dislocated. These are the cuts from the CT scan, and these are 3D images from the CT scan showing posterior lateral dislocation of the elbow with the radial head comminuted fracture. So based on the findings of the CT scan, once again, close reduction was attempted within the ward under the hematoma block, which was unsuccessful. And then he was planned, and then we plan to move him to OR as a red case for reduction and fixation. So intraoperatively, the findings that were observed were comminuted fracture of the radial head and near complete tear, rupture of the LCL, rupture of MCL, and stretched and thinned out ulnar nerve. The fracture was fixed with one Herbert screw, mini fragment 3-hole T-plate, and 1 K-wire. These are his post-operative X-rays. On follow-up, his active issues were restriction of pronation and supination. The wound, although healed uneventfully. The median nerve was intact, and there was, on the examination of ulnar nerve, there was atrophy of first dorsal interosseous muscles, FDP 3 and 4, had power of +4. The examination of radial nerve revealed absent wrist extension and absent thumb extension. So he was advised EMG and CS and was counseled regarding possible need for tendon transfer in future. On 3 months follow-up, the EMG was done that showed a right PIN mononeuropathy localized at its origin. Axon loss was severe in degree, and active motor axon loss changes are seen in most PIN innervated muscles. On 4th month follow-up, his range of motion improved and the neurology started to recover as well. So these are his videos for the 4th post-operative month. Here we can see near complete restoration of pronation and supination along with opposition. and there is some degree of flexion contracture on his right elbow, but the range of motion is, other than that, it's intact. So while dealing with a complex elbow dislocation fracture, the treatment goals are restoration of the stable trochlear notch and maintenance of proper joint alignment while the collateral ligaments heal. So in this study, this is a meta-analysis done, and it compared fixation versus replacement of radial head. In this meta-analysis, 9 studies involving 210 patients were included. 98 radial head replacements and 112 radial head reconstructions were analyzed, and there was no statistical difference between them. The outcome measure they used was Mayo elbow performance score. This is another retrospective cohort study, and what they did was review X-rays post-operatively, and they found recurrent stability in 19.7% of high-energy traumas, and the factors associated were factors that were associated with recurrent stability involved time between injury and operation, and radial head combination, medial collateral injury, and coronoid non-repair. The dislocation pattern, along with its associated bony fracture, historically has poor outcomes with a tendency for early recurrent instability, chronic instability, and post-traumatic arthritis. Thank you. So we started with the standard approach, and the fractures were reduced. First of all, the two parts of radial head were aligned. The radial head's articular surface was recreated. So first of all, we fixed the radial head with a Hubbard screw, and no, sir.
So our planning was to fix everything, whatever is broken, and to restore the ulnar nerve and repair collateral ligaments. This was our planning, and executed for both medial and lateral incision. So initially we did the approach was lateral. Yeah, first approach was lateral, using the interval between enconius and extensor carpi ulnaris. So we fixed the radial head, and then repair the lateral collateral ligament with some rolls. We didn't utilize suture anchors, so just by drilling and using strong fiber. पहले हमने reduce किया, तो open reduction की and affect the radial head, or then we repaired the collateral ligament, then we passed the wire. This was
वो नाइट स्कूल निकालती थी, early निकालती थी, and that is दिखाने का भी मकसद ये था not having a lot of volume about such type of injuries. So recently I saw a case in my clinic where similar injury, not so severe, and somebody only did radial head excision, right? So now he is in the city. पहले तो वो किसी के पास चला गया, अब वो कहता है कि मैंने रेडियल हेड रिप्लेसमेंट करवानी है। मैंने कहा अल्लाह के बंदे जो तुम्हारे मसले वो तो हल करो। He has a gross instability of the elbow involved joint. So ये मुझसे था कि I think in trauma situation like this, radial head excision is almost contraindicated. तो किस चीज की? हाँ वो बस हमारा ख्याल नहीं था कि ये कोई बहुत अच्छा काम हम कर रहे हैं, पिक्चर लेके इम्प्रेस करें तो वो खुद भी परेशान थे यार, इतनी सीवियर इंजरी है कि करेंगे क्या। हाँ हाँ रिकवर हो गई, या तो ये इतनी बिग इम्पैक्ट थी कि या तो हम उस तक पहुंचे नहीं, जो कि मेरा नहीं ख्याल की जो पे होगी, क्योंकि ना मैं एक्सप्लोरेशन में मेरा काफी एक्सपीरियंस है, और लेकिन फैट बहुत बिटन थी उस साइड पर, सारा हिसाब से कुछ खराब था। मैंने कहा और ना कोई लाले पड़ जाए, ये स्किन में क्लोज हो जाए, तो उसको ज्यादा हमने फिट नहीं है, उसको छोड़ा। मिली थी एक फ्लैट सा था, वो हमारा ख्याल था ये ना मैं इसको ना चेक, हाँ वो जो कुछ भी कंटिन्यूटी उसकी है उसको ना चेक, हाँ रिकवर कर गया। ये बड़ी इट इज अ सरप्राइज टू मी आल्सो, और रेंज ऑफ मोशन बड़ी अच्छी होगी। आई थिंक दैट इज आर रिलेटेड टू
Thank you.
So now we'll be moving to the sports section. So the topic for sports section is PCL avulsion. Supervising faculty is Dr. Naveed Juman and presenting resident is Dr. Wajahat.
Assalamu alaikum everyone. My name is Dr. Wajahat and I'm going to be presenting my presentation on posterior cruciate avulsion fracture, which was supervised by Dr. Naveed Juman. So, time history, we have a 34-year-old male patient, no comorbid. He presented to us in the ER with history of RT. And the mechanism of injury was he slipped from his bike while he was riding, and it was 4 days prior to the presentation. And main query was that he was limping gait. He had a limping gait. There was swelling around his knee joint, and there was pain as well. So, going to past history of this patient is known to the AQ service of orthopedic department from since 1988. First time he presented for surgery for septic hip arthritis in 1988. Then he underwent hip reconstruction osteotomy in 2005 with the left shoulder bistro procedure done in 2016, right calcaneal fracture fixation done in 2017, and remove implant from the calcaneal fixation in 2018. So hip surgery की left side की हुई थी. On examination, he was a young male, well-oriented, conscious, and he was oriented to time and date in person. On presentation, we had externally rotated left lower limb, and there was a healthy scar mark. There was a posterior sex sign was positive. There was tenderness on the posterior aspect of knee, with the range of motion which was limited from 0 to 90 degrees. Pulses were present, and distal nerve was intact. So these are the postoperative X-rays on which we can appreciate that there's in the left limb on the AP view, the femur is already deformed the limb, and on the AP, but which is well healed and well aligned to the circumstances which the patient has presented to us. And on the lateral aspect, we can see there is a fragment of the posterior facet of the tibia, which is avulsed, on which the posterior the PCL is attached. And on the classification, if we go it on the CT scan, it can be more bit clear. This fragment is clear enough to say that it's distally the focal facet discontinuity on the posterior aspect. On the classification, it's a type 3 classification, and they state that which is around 10 mm of the displacement, which is also radiologically visible. If the displacements are less than 10 mm or around between 6 to 8 mm, they're not radiologically visible enough. So our radiology, our displacement is well radiologically visible. So it's a 10 mm and type grade 3 classification of the PCL injury. Our plan or surgical plan was to do arthroscopic PCL fixation with endo-button technique. And our mode of that, we made 2 standard ports, which were made on the anterior aspect medially and laterally, and 2 posterior ports were made. Keeping in mind that posteriorly vital structures pass through, these are the popliteal artery, popliteal vein, and the tibial nerve which pass by, and there's a chance that we may breach them. So we made special care, and I think the nature was kind enough to us that our posterior port that we made was that it was medially, posterior medially superiorly, and posterior medially inferiorly. Though posterior medial portal is difficult to make, but since the patient had already external rotated limb, it gave us this an advantage to make a port which posterior port which was easy to the naked eye. So this is the arthroscopic image that we can show that this is the PCL ligament which is intact, but obviously it is avulsed from its insertion site, the bony impact, and this is the tunneling that we are doing. There's a slide video that I want to present show that while we were making the tunnel for the PCL fixation. The end product, the result was that we were able to in place the PCL endo button, and PCL was well fixed until we can see the ACL which is intact, and PCL ligament is also well placed intact. The outcome, what we can see that it is a well fixed implantation that we have placed, and there's the button that we've placed. The procedure that we do is that we place from the anterior, we make standard ports anteriorly, placing the knee in 90-degree position, and we pass around guide wire onto which first we place the ACL reamer guider, which neutralizes the fracture, and then we pass the guide wire of the PCL to maintain the fragment position. Then we pass the endo button drill onto the guide wire once it's done enough, so it maintains the procedure. And then from the anterior aspect, we pass a flexi suture passer, which goes down up to the retrograde aspect of the knee, and from the medial port, we remove it so that we make a loop out of it. Then passing a flexi stick, which a loop from the endo button, and the limbs of the flexi stick are brought from the loop that we have previously taken out from the medial port. It is pulled down the endo button, which snugs the PCL fragment into its original anatomical position. And the outcome is this, that it is anatomically placed in its position, and the end tied of the fibroelastic loop is placed with a posting screw on the tibial aspect. So post-operatively, this is the outcome of the patient. Sorry. He was able to sit without support, could walk very comfortably, and there's no pain without ambulation. And obviously there's slight limping on this leg because it has already been operated and for deformity correction. Thank you. Sir, well, this was it was minimally invasive technique. We wanted to do it. It's something that no, it's not that much. So we didn't articulate. That's the reason I'm saying we never violated the. We did, but we never maintained. Yes, sir. Yes, sir. Sir, the chances of open normally it's an injury which is not it's just treated conservatively. Most times, a very rare type of injury that comes around. Normally, we do get to see. And side was to secure the ligament, and since patient was a very active mobile patient, and we wanted to maintain. Was just screw. Uh,
Multiple options, including open as well, screw, button, or some kind of different suture technique. So, but then again, it's the same argument that why we do open rotator cuff, why not, why arthroscopic, why not open, why don't we do open Bankart, why arthroscopic Bankart? So these are new techniques, new innovations, less invasive, less scarring, and probably potential of less complications. And that's why, I mean, we want to go for these techniques.
So when you put screws, how long you keep the patient immobilized with the knee? You have to put them immobilized until the fragment is healed before you can allow some knee range of movement and everything. With these implants, the newer techniques, and arthroscopically, once it's fixed with the endo button, we actually can allow very early range of movement exercises to gain full range of movement and early return to function. That's the whole idea of doing arthroscopic PCL. Now, he described it very well. It's not as easy as what he was saying. Of course, you have to, it's very technically demanding. I only saw the last bit of, I missed part of the presentation. It was very nice anyway. I just only saw the last bit of it. And then certainly early in younger patients, and particularly who are active, highly recommended do an arthroscopic, because that allows very quick return to work and very quick rehab. We don't have, in our society, we don't have extra source of income. If you are not working, you're sitting at home, no one is paying you for that. So the sooner you get back to your routine, the better it is. So that's the whole idea. And someone is coming to our Khan, has no issues with the money, you know that. So that's you can say that in civil hospital, but not at AKU. So
हटा दूं मैं इसे?
yeah, no, as I said, for the AC, for both for ligament reconstructions, we all of us who are doing ligament reconstructions in Karachi and around Pakistan, I think the whole idea is to have early return to work. I know the implants, particularly nowadays, the implants are expensive with the conversion rate and everything. But having said that, and that's the ideal treatment now. It's more kind of, we have moved from open and putting screws or metals, and now we have these endo buttons. They are excellent implants to use for these reconstructions.
I mean, I totally agree with Dr. Pracha. Cost is an issue, obviously. We should not be going for this technique in each and every patient, in every institution. And one thing was surprising when we did the literature search ourselves. Obviously, there are advantages which you described: early range of motion with this implant, less complication, less scarring, minimal invasive. But unfortunately, literature is still showing there may be more stiffness in the knee with arthroscopic techniques than the open one. So, and it was surprising for us to read as well. So it may be possible because the older techniques which are described, you have make one medial port, one lateral port posteriorly, and you breach the septum, just like you do the PCL reconstruction. But this is a little bit modified technique. So we are not breaching the septum, and we are not making a lateral port. There are two posterior medial ports, one for visualization and one for instrumentation. So we believe probably this is a relatively new technique described in literature, and it may give rise to less scarring and may improve the outcome which was previously shown as compromise.
Thank you, Dr. Naveed. We will be now proceeding to the last segment, that is the tumor segment. So the topic is wide margin excision is large sacral tumor and its outcome. The supervising faculty is Dr. Masood Umar and presenting resident is Dr. Ziad Ali.
यार मुझे नहीं पता किसको इतनी गर्मी लग रही है, लेकिन क्या हम एसी बंद करवा सकते हैं?
सही बात.
यार कितना खाएं?
So, Bismillahirrahmanirrahim. My name is Dr. Ziad, and I'll present two cases of sacral tumor. The first case is sacral GCT, and my work is being supervised by Dr. Masood Umar and Dr. Akbar Jalil. So the patient presented to us with history of 31-year-old female. She was married with no prior comorbids. She was presented to us with lower back pain from 1.5 years, and she was complaining that the pain is increased from February 21 after her delivery, and there was stated difficulty in her routine activities. Her past medical history was she was diagnosed case of sacral GCD from outside AKU, and she underwent a debulking procedure with partial sacrectomy from outside AKU in March 2021. And then in her post-op MRI showed a residual disease, and she also developed post-op episode of urinary retention and stool incontinence. Then again these were the lobulated infiltrating soft tissue density sacrococcygeal region, erosions of the sacrum and the coccygeal vertebra, and extending to the presacral space. So she presented to us for further management. So she underwent denosumab injection 5 cycle. Last one was done in the July 2021. And after the MRI done from AQ in the July showed the redemonstration of extension of lesion in posterior wall of the rectum and surrounding sacral plexus. So these are the sagittal, coronal, and axial images of the MRI showing large tumor mass involving the sacrum. Similarly, there is the previous surgical scar you can see, and so it was extensive mass. So these were our preoperative planning. Our plan was to do wide margin excision plus gluteal rotational play by our plastic surgery team, and bilateral open-ended catheter and suprapubic catheterization, and laparotomy and colostomy, as the rectum was also involved in this case. So this was our preoperative image showing the previous surgical scar, and these were the resected wide margin was done, and this was the resected sacrum with bowel. So these are the post-op. Now these are the follow-up clinical visit video. You can see that she can now ambulated. She's back free, and she can do her hip and knee range of motion.
Okay.
And good power. Left वाला उठा ले straight. बिल्कुल straight नहीं कर सकती. ठीक है. अभी मैं नीचे push करूँगा, आपने resist करना है, ठीक है? ठीक है. ये वाला उठा दे. ठीक है. अभी घुटना मोड़ के दिखाएं. मेरे हाथ को push करें. अपनी तरफ. ठीक है. ये वाला push करें. मेरे हाथों को push करें. ऊपर की तरफ. ठीक है. ये और ये साथ चले आ जाएं. So there is literature review regarding the preoperative denosumab treatment as the tendency to reduce the blood supply and intraoperative bleeding of sacral GCT. There is another retrospective study regarding the sacral giant cell tumor treated with nerve-sparing surgery in evaluation and therapeutic benefits of denosumab therapy, and they showed that it reduced the intraoperative hemorrhage and was treated with shorter operating time. Adjuvant denosumab was useful to prevent early recurrence during the first 2 years of surgery. Thank you. There is another Uh, Maybe I have missed. I think I haven't edited it. Yes, sir. In colostomy, because rectum was involved. So our surgery, general surgery team did in colostomy. Yes.
And the what?
They have good power in the foot and
So L5S1 is intact, sir. Sciatic nerves both were preserved. That's what he
Yes.
failed to explain. Both sciatic nerves were identified in the below the SI joint and preserved, and sacrectomy was performed, sacrificing the S2, 3, 4 roots. Hence, colostomy and ureterostomy was required. She was incontinent pre-op also, so we had counseled her for that. The management of the colostomy bag and the urine bag all were explained thoroughly by respective surgical teams, and thereafter the procedure was executed. S1 bone intact है ना, तो we were able to save the S1 root also. उसके लिए we had to do some extra dissection. L5 तो वैसे ही ऊपर से आ रहा था, intact था, और S1 को हमने preserve किया, तो उसका इसलिए foot function पूरा है.
So this is another case of recurrent cardoma. She was 54-year-old female with known case of male with known case of hypertension and BPH, presented to us with lower back pain from 2 months. He has history of cardoma excision in October 19 in Peshawar. He has no other neurological deficit. He was just complaining of on and off constipation. On examination, he had yield scar mark on the lower back. He has normal gait. There was no neurological deficit, and he was able. There was no palpable mass. Workup was done. The CT guided biopsy was done with short chordoma, and MRI pelvis was done in September 2022, which shows the large tumor involving the right pararectal region, extending to the posterior wall of the rectum, and right quadrant of the prostate, and posteriorly it extends to the paraspinal muscle and the gluteal muscle, and there are also mets in the soft tissue met in the paraspinal region at the L5 level. So our plan was to do the wide margin excision, and DJ stenting was bilateral DJ stenting by urology team, and general surgery team was taken in loop for laparotomy and permanent stoma, and plastic surgery performed the ventral rectus abdominis muscle flap, and the patient was positioned in the jackknife position, and after the separation of nerve roots from the tumor and secrectomy at the S1 S2 level was done. Resection of prostate and prostatic urethra with permanent suprapubic catheterization was done, and this was in the one stage procedure in which was lasted for almost 15 hours. And in the second stage we performed a stage sacral wound repair with mesh and flap. So this was the our marking. This is the L5 level where there was tumor, and this was our original incision, and this was the part where which was mainly involved. So this is another preoperative planning image. So this was the preoperative image that was taken. You can see the patient was put in the jackknife position, and these are the surface marking of the sacrum, and this was the original incision, and this part is the involved portion of the soft tissue at the L5 level. So this is the resected mass involving the prostate and the prostatic urethra and part of the rectum. And these are the immediate post-op images in which the stoma is placed and the flap is placed. So the post-op, the patient was sent to ICU, and total 11 PEG cells were transfused, 6 platelets and 8 FFPs were transfused. And the surgery, the first surgery lasted for almost 15 hours, and the second lasted for almost 6 hours. So our overall our margin were quite extensive, and only the minimal resected margin was 0.5 centimeter. And this is the post-op video in his clinical visit.
आपका एक काफी पेचीदा सेक्रल
इसकी साउंड
बोन की सर्जरी हुई तो पहले भी
इसकी
से पहले शावर में कब हुई थी? शावर में
वो मैं म्यूट की थी मैंने। इसकी वो ये यहाँ
क्या हाल है? कैसे हैं? आपका एक काफ़ी पेचीदा सेक्रल बोन की सर्जरी हुई तो पहले भी इससे पहले शावर में कब हुई थी? शावर में 3 साल पहले। 3 साल तो अब हमारी दोबारा आ गई आपकी वापस? जी दोबारा आ गई। तो हमारा रेफरेंस कहाँ से पता चला आपको? हमारा एक डॉक्टर जनरल है दुबई में, स्पेशलिस्ट ऑर्थोपेडिक, उन्होंने आपका मुझे बताया था कि उनके क्या हाल है? कैसे हैं? तो आपका एक काफ़ी पेचीदा सेक्रल बोन की सर्जरी हुई तो पहले भी इससे पहले शावर में कब हुई थी? शावर में 3 साल पहले। 3 साल तो अब हमारी दोबारा आ गई आपकी वापस? जी दोबारा आ गई। तो हमारा रेफरेंस कहाँ से पता चला आपको? हमारा एक डॉक्टर जनरल है दुबई में, स्पेशलिस्ट ऑर्थोपेडिक, उन्होंने आपका मुझे बताया था कि उनके पास चले जाएँ, खान में सबसे बेहतरीन किस्म के डॉक्टर हुई। तो आपका तकरीबन हुआ है तकरीबन 16.5 घंटे का एक ऑपरेशन और 5.5 घंटे का एक ऑपरेशन। पहले दिन 16.5 घंटे, दूसरे दिन 5.5 घंटे, ठीक है ना? वो तकरीबन 24-36 घंटे बाद हुआ था दूसरा। जी। फिर आप आईसीयू में रहे कुछ दिन, वार्ड में रहे, तो कैसा आपका तजर्बा रहा आगा खान हॉस्पिटल में? और इतने सारे तकरीबन 6 सर्जन्स ने आपका ऑपरेशन मिल के किया है? जी मैं बहुत मुतमईन हूँ, बहुत अच्छा रहा, बिहेव भी बहुत अच्छा रहा, उसके बाद जो है ना हर तरह के लिहाज से बहुत अच्छा, मैं मुतमईन हूँ इस चीज़ से। तो अब आप चलने की स्टेज पे अल्लाह का शुक्र है आ गए हैं, इससे आप मुतमईन हैं? गो के अभी मैं देख रहा हूँ कि नलकियाँ तो कुछ अर्सा रहेंगी आपको, लेकिन कम से कम आप अपने रोज़मर्रा के मामूलात कुछ वॉक करके पूरे कर रहे हैं? अभी तो मैं चाह रहा हूँ थोड़ा सा होटल ही में चाह रहा हूँ। उसमें कॉन्फिडेंस आ रहा है आपको? जी आ रहा है उसमें, थोड़े से चक्कर आते हैं बाहर टाइम, लेकिन अब थोड़ा ख़त्म होने शुरू हो गए, पहले आ रहे थे अब ख़त्म होने शुरू हो गए, और अब चलना ही मैंने थोड़ा ज़्यादा कर दिया, पहले उस एक चक्कर लगाता था, अब 2 या 3 चक्कर लगाता हूँ, शुरू कर दिया। तो सिर्फ जो है ना बस यहाँ से थोड़ा दर्द रहता है टांगों में, बाकी ठीक है इंशाअल्लाह। अल्लाह ताला आपको सेहत दे। बहुत शुक्रिया आपका, बहुत शुक्रिया। क्या हाल है?
So this is a literature review regarding the disease-free eradication in chordoma is rare and not with neurological deficit. The common sacral nerves involved is 2S3 have to be sacrificed to achieve adequate margins. While wide margin excision through posterior surgery show a decrease in recurrence, the overall survival still remains low. This is another study, low dose radiotherapy is associated with local complication but not disease control in sacral carcinoma. In this multi-center review, radiotherapy was not associated with tumor outcome but associated with complication. The routine use of the radiotherapy with in-block resection of sacrococcygeal carcinoma should be reconsidered in favor of a selective individualized approach with a radiation dose of greater than 70 Gauss. So there is another study comparison of wide margin and adequate margin per resection in sacral carcinoma. Wide margin is associated with low recurrence risk. When it is feasible, a wide excision should be considered appropriate for sacral carcinoma. Using a combination of surgical resection, adjuvant radiotherapy allowed us to obtain a good overall survival, local relapse-free survival, and distant relapse-free survival in patients presenting with either primary tumor or with first-time local recurrent tumor. So the conclusion is that this is the major procedure, especially when such large tumors involving sacral region with nerve plexus around. It required multidisciplinary approach. As you can see in this case, in both these cases, we required almost 7 surgeons, general surgeon, plastic surgeon, urologist, and orthopedic surgeon. So it is a multidisciplinary approach, and one has to have proper oncological surgery training and proper ICU care, because these patients do develop complication operative and post-operative. So a wide margin excision should be done in these cases. Thank you.
Thank you, Dr. Masood and Dr. Ziad. Thank you for all the residents for their presentations and faculty for their input. I would now hand over the stage to Dr. Masood Umar for closing remarks. Thank you.
Thank you very much for your patient audience. I hope there are some good take-home messages from these clinical cases that we have strived to provide the audience today. This is also a reflection of our service, orthopedic services at AKU, and a reflection also of the super specialized nature of surgeries that we perform, and the dedication of our faculty towards this super specialization procedures. We have now very well trained pelvic acetabular faculty, oncology faculty, foot and ankle faculty, hand surgery is very well established here. You saw an extreme case of brachial plexus management. Microvascular surgery is very well established. So we are gradually over the last 5 or 6 years moving more and more into super specialized surgery and diverting our faculty, especially junior faculty, into managing these complex cases on an individualized basis rather than any random basis like any case coming to anybody. So that approach has helped us to reach the stage where we have very selected practice, clinical practice, and this has also led to intra-service referral where a person is managing, for example, deformity, a person is managing, a small group is managing hand problems and microvascular issues, and whatever you saw today is just a reflection of that. So I would just stop here, and we have a small exercise where I would request the faculty to have a electronic voting exercise, a replica which we have done, but in the past also, but Dr. K.K. Saab is here as Chief Election Commissioner, and with his permission, sir, we can start a dummy voting process so that next 2 weeks we will be in Islamabad doing the actual voting process on this. We have our special guest, Dr. Josh Shoaib Khan from Peshawar, to oversee this process also. I'm very happy, sir, and welcome you to our meeting. Professor Parvez Anjum Saab, past president, is also here. So I please request you to please all proceed, faculty members, to the outside of the auditorium where we have placed those screens, and then we will follow on the other side of the auditorium for lunch. Thank you. Residents can proceed for lunch. Good job by all residents. Good presentations.